Thank you all for coming out. I'm Dr. Edward Bergen. My partner, Chris Thompson. Our other partner, Greg Lugo, would be here, but he's tied up in the OR. So he's the missing surgical part of our team. So very exciting time here. You know, this has been an ongoing process for us for literally over a year, developing this program, and it entailed quite a bit from multiple parties. There's too many people to thank, but nonetheless, myself and Dr. Thompson have literally traveled the world from, Munich, Germany to Houston, to St. Louis, to even Baton Rouge to get all the requisite training and experience to do this. And Dr. Lugo, he already had a program prior to coming here, so he actually has the most experience of anyone in this area. And multiple other folks, but we'll move on. So what are we talking about today? 4 valves in the heart. The one we're targeting here is the aortic valve. And what occurs over time, just like any valve in your house plumbing, they begin to degenerate and not work well. And specifically, there's 2 things: either stenosis, meaning it doesn't open all the way, or regurgitation, where the blood leaks backwards. This is just kind of a cartoon depiction of what, this is hopefully what my valve looks like right now. And, this is what we're talking about. Over time, it gets worn, you get calcium deposits, and the leaflets of the valve just can't open. And what that does is your heart starts to struggle. If you can imagine, it's like a hose. And when you twist the hose, the pressure builds up. Well, the same in the heart. When this valve doesn't open, the heart has to work harder, and it thickens, and slowly the cavity closes up. And over time, if untreated, then the heart dilates out. You get congestive heart failure and a multitude of other issues that go along with that. So what are the symptoms? Highly patient-specific. The classic triad that people like to talk about is exertional chest pain, breathing problems, and then passing out. But I can tell you that, at least in my humble experience, the most common thing we see is breathing problems, but just fatigue. Oftentimes people, just complain that they can't do what they wanted to do. And this tends to be a very insidious process. So oftentimes folks change their lifestyles to accommodate what they can do, and don't actually appreciate it because it is such a slow, progressive process. So causes, we kind of alluded to that, but the biggest one here is just the aging process and calcium. There's a couple more rare things, rheumatic fever, which is basically unheard of in the United States, or I shouldn't say unheard of, exquisitely rare. Radiation therapy, so if you had a malignancy and you had some chest irradiation, that can certainly quicken the process. So who's at risk? Well, the older you get, the more likelihood you are to have aortic stenosis. You can see here, once you hit 75, over 12%. And just given the demographics of our country, you can see how this is going to be quite an issue, increasing exponentially in the near future. So how serious is it? Very serious. Once you develop symptoms, your likelihood of being alive in 2 years is a flip of the coin. So it's not something to take lightly. So what are the treatments? We have medicines up here. I can tell you there's no medicine in the world that's going to dissolve that calcium and make your valve open, okay? So you can kind of X that one out. Balloon valvuloplasty is a good option as a bridge to something. We don't use it that frequently just because we do have more definitive options, but it's certainly, there's certain patient specifics. In fact, we have one coming up here shortly where that is the game plan. And that's basically just putting a balloon across the valve and we crack it open. We tend to have reasonable acute results, but the long-term durability just isn't there. Surgical, thankfully, and I can proudly say at this institution, we offer everything. And Dr. Lugo doesn't just do the traditional sternotomy, he does what we call a mini AVR, so less morbidity, basically a safer surgical valve that you recover quickly from. And then, of course, what we're kind of focused on here today is the transcatheter, which For the most part, we go through the groin, but again, there's what we call alternate accesses. There's other ways we can get there from the arm, and even directly through the aorta, which actually we've done one where Dr. Lugo makes a tiny little incision in the chest, and we can get to the heart that way. So a lot of options. Which test is, this is not, you come into a hospital and, hey, you have severe aortic stenosis, we're going to do a TAVR tomorrow. That's not the way it works. There's a very comprehensive workup. And unlike a lot of things Chris and I do, it's, a lot of times we take folks to the cath lab and we're making a lot of decisions there on what exactly we're going to do and what kinds of stents and what size. This is a lot different, which is, I think, it's different for me and Chris to get used to this. It's just 95% of everything is decided before we actually step in the room to do the procedure, which is actually pretty nice. Hopefully. But nonetheless, part of the workup is an echocardiogram. That's basically where we start to make the diagnosis. It's where we look at the valve, and there's a bunch of numbers we look at. There's a lot of physics I'll save you all from, but how to quantify how severe the blockage in the valve is. Coronary angiogram, we have to look, see what their arteries look like. That factors greatly into where we go with this. And this has really revolutionized everything, even in the TAVR business. A gated CAT scan, which is basically X-ray pictures. We take multiple slices and we can see everything, and most importantly, measure precisely the size of what valve you need. Initially, when TAVR started getting going, everything was predicated on the findings on the echocardiogram. And what we learned from that is we tend to undersize the valves. So the CAT scan has really helped. And the other issue with the CAT scan is for us to figure out as a team how we're going to get to your heart. Again, we prefer to go through the groin, but sometimes we can't. If the arteries are too small, too heavily calcified, then we have to look at other options. Excuse me. Carotid ultrasound to look at your carotid artery, see if you have any blockages there. That kind of just factors into the risk of the procedure for you. Pulmonary function tests, very important. A lot of folks have concomitant disease with their lungs, and that can factor into what we do as far as general anesthesia, not using general anesthesia, and recovery, and also just to see how much you're going to benefit. Okay, a lot of times, folks, it's rare that we get somebody that they just have aortic stenosis. There's usually a lot of other things going on, so we have to, as a team, sit down and factor in how much of this is coming from the valve, how much is coming from blockages in the arteries, how much is coming from the lungs, deconditioning, etc., to see who's going to really benefit from the procedure. Frailty, that's kind of self-explanatory, but there's a couple tests Misty does on the folks that come to our clinic to assess how frail folks are. The evaluation, see at least one of us from a cardiology perspective, and then see Dr. Lugo, and we have another surgeon who works well with us to come in and help out. That's more for, we have to have two surgeons, long story, but as of right now, that's what we have to do. And then the treatment plan. Chris and I joke about this a lot now. We didn't realize how much time that we would be spending with this program. It's very in-depth, and we meet as a team every, Friday morning at 7, and we get input from everyone, to come up with a definitive game plan. Number one, are we going to go surgical aortic valve? If surgical, is Dr. Lugo going to do sternotomy and mini? Or are we going to do transcatheter? If we are, what access are we going to use? So a lot that goes into this planning. Here's our wonderful team. Proud to call them my team. This was a picture actually of first day, right after we got done with Ms. Hawkins down there. We reconvened as a team. Other than me and Chris, this is Greg and everyone else from anesthesia, the cath lab, OR, all the nurses, all the techs. It's quite a comprehensive group of folks we have here. So what are your options? We kind of already alluded to this. Surgical. Once again, you have two options. Either Dr. Lugo does a sternotomy or what he calls a mini. Both of them require going on bypass. So the TAVR, which is kind of what we're focused on here today, this is on a beating heart. So this is one of the major benefits why folks recover better. You don't have to go on the heart pump machine, which sometimes everyone's body responds differently and it can take a little longer to recover. But this is on a beating heart. And again, you could be under general anesthesia, which I think the majority are, but there's a push to use in what we call conscious sedation. If you all ever had a colonoscopy or something where you go in and get sedated and have a procedure done, that's kind of the push to do that. So if you can avoid a heart-lung machine and you can avoid general anesthesia and you can avoid a big incision, intuitively makes sense that the recovery would be a lot quicker. So who's eligible? Everyone in this room, as long as you have severe symptomatic aortic stenosis. There's only one demographic that is excluded. So we plug all our numbers in, look at all your comorbidities, and we come up with who's low risk, intermediate risk, high risk, or prohibitive risk of surgery. So if you're anything but low risk, the transcatheter is an option. And I can tell you that the trials looking at folks who are low risk are ongoing, and all the data is basically equivalent. And I think, Chris will agree with me, we would all be dumbfounded if the trials end up showing that low risk is not as beneficial as surgery. So, how is it performed? Come to the cath lab, you either get sedated or intubated, general anesthesia, either option. And basically every case, it's all three of us, Dr. Thompson, myself, and Dr. Lugo. And depending on the access, so for the most part, it's all through the groin on both sides, because we have to take pictures from one side as we're positioning the valve from the other. And I think Misty has a video for you all to watch.
I'll just have to play it like this.
So here's the valve coming up across this aortic valve. We pace the heart very rapidly, and the reason we do that is so it can't move. And the valve itself, if you can imagine what we call crimping. Now if you have a valve and it's a metal frame and it gets crimped onto a balloon, the balloon then crosses the valve, and when you expand the balloon, then the valve deploys in the heart. This is actually where we place the balloon onto the valve. Notice this is a wire that's been placed across the aortic valve. Can you all see there on your way? So now notice the heart. You see the heart's kind of beating normal here. You'll see pretty soon it'll speed up. There's a lot of little things we look at for positioning this. Really crucial. You see how the heart looks like it's quivering? That's from what we call rapid pacing, again, so there's no movement. And then the balloon is expanded and the valve's deployed.
That part shows it.
You can see here, these are the leaflets. You're going to look down on it. Looks kind of like a Mercedes-Benz sign here. Only the best. So it's a proven treatment option. This is, it's new here, but this has been going on for a long time, okay? And you can see here over 150,000 implanted worldwide, obviously multinational. And the first approval, I can't believe it, but was 7 years ago. And this is Bonnie, number one. You want to come up, Bonnie, and say a couple words? Thanks for coming.
Hi, my name's Bonnie Hawkins. I'm 79 years old, and I was the first patient here at Memorial to get this done. I was a nurse for 30 years, and whenever they told me, Dr. Thompson found it, told me I needed a new aortic valve, I told him yes, almost right away. The first thing I felt after I had surgery was a less brain fog, I call it. Because as you get older, you get it.
Okay, welcome to IVCC again, and you will have seen the case history here.
I'm sorry. Sorry about that.
Would you like to comment
All right, let's try that again. Here you go, Miss Bonnie.
Well, there goes my fame and fortune. But even now, as I'm healing, I've been a month now, and things just keep getting better and better. I couldn't walk across my backyard, which is very small, without my breath being very labored. And my legs were always swollen. They're not now, somewhat, yes, because I'm nearly 80. But I'm very proud of that, too. The team was wonderful. I went through all kind of scans, etc., and they double-checked everything, and it was great. If you have any question, I'll be glad to answer them. None? Okay.
Thanks, buddy.
Thanks, Bonnie.
Thank you.
We have a question for you.
Yes.
This young man has a question.
Do you feel different now than you did before?
Oh, yes, almost immediately. When I came out of the sedative that they had given me, I felt more clear in, seeing what was going on. I just felt better. And I only stayed in a couple of days. And then when I walked across the yard to visit a neighbor, and I didn't have to gasp for breath, I was very excited, very excited. And now I can sit in front of my computer with a clearer mind, better legs, and it's just been marvelous. So I would recommend you find a very good memorial doctor. That's what I did. And let them look you over real good and reap the benefits as you need. Thank you.
Yeah.
How do you measure tiredness?
Well, I mean, it's not necessarily a measurement of that. It's just a, clinical assessment. When we come to there are certain things like that one, they talked about frailty and stuff, and there are certain grip strengths, how fast you walk a certain distance. There's some measurements that we look at. I mean, tiredness is kind of a subjective thing. I mean, and we ask you questions, getting dressed, walking across a room, going to the store, doing things at your house, and it's kind of a give and take between your doctor and you as far as what you could do maybe a month ago, 6 months ago, a year ago, and just as far as what where we think you are compared to where you maybe should be or where you were before. Sometimes it is a little difficult to to get those answers, but I mean that's what it's helpful to have your primary care doctor involved who may have seen you for a couple of years and say, man, I remember when you could do X, Y, Z, and now you can't do that, you know. So I mean, it does have it's helpful to have, you know, those kind of people have input as well, and family members that will say, yeah, I remember Dad could do this, or now I can't. And so those things are, you know, sometimes it takes a little extra time and effort.